Thank you, Jen, and welcome everyone to this evening's really fine program. We have three superb faculty that I'm going to present now. Our first speaker, Dr. Bernardo Bizzo, MD, PhD, is a trained diagnostic radiologist and a faculty member of the Radiology Department at Massachusetts General Hospital, and he is an assistant professor of radiology at Harvard Medical School. He is a senior director at the Mass General Brigham, known as the MGB, Data Science Office, and leads its digital clinical research organization as a CRO. Dr. Bizzo is a senior scientist at the American College of Radiology Data Science Institute, and he is a member of the ACR's Commission on Informatics. His work and research focus on the development, validation, and implementation of AI applications. Dr. Bizzo has led the development of over a dozen clinical AI applications over the past 7 years, collaborating with the MGB clinical and research investigators and industry partners. He and his team at the Digital CRO are responsible for designing and conducting AI validation studies for regulatory clearance and clinical implementation at MGB. Our second faculty member, Dr. Tessa Cook, is an associate professor of radiology at the Perelman School of Medicine at the University of Pennsylvania in Philadelphia, and she is the vice chair of practice transformation in the Department of Radiology. She is the director of Imaging Informatics Fellowship and modality chief of the 3D and Advanced Imaging section. Dr. Cook is the chair of the Society for Imaging Informatics in Medicine, known as SIM, S-I-I-M. In 2020, she was inducted into the College of SIM Fellows and received SIM's Dr. Ruth Dayhoff Award for the advancement of women in medical imaging informatics. Tessa pursues innovative methods to enhance care delivery in radiology and to improve radiologists' workflow. Our third faculty member, Dr. Paul Yee, is a director of the University of Maryland Medical Intelligent Imaging, known as the UM2II Center, and assistant professor of diagnostic radiology and nuclear medicine. He is also adjunct assistant professor of bioengineering at the University of Maryland in College Park, and he is an adjunct research scientist at the Johns Hopkins Malone Center for Engineering and Healthcare. As a practicing physician and scientist, his current research interests include the development of AI and deep learning towards medical imaging applications, with a special focus in evaluating the trustworthiness and fairness of deep learning models. It's a tremendous pleasure to have these three strong faculty members with us tonight. And we're going to start off next with Dr. Bizzo. Dr. Bizzo?
Thank you, Bob, and thank you, everyone. It's a pleasure to be here tonight. Let me share my screen. Perfect. All right, so I will skip the intro since Bob was kind enough with introducing myself. So I'll jump straight into the discussion today. So in my role at the Mass General Brigham Data Science Office over the last 7 years, we established a number of strategic collaborations with key industry players and built an AI ecosystem to support all aspects of what we call the AI product journey. And today I will walk you through this journey divided into 3 main parts, starting with AI product development, how we develop software as a medical device. Then we will discuss AI validation, both for an FDA clearance, as well as to ensure these models work before clinical use in our institution. And we'll finish with clinical integration and our framework for AI governance. So starting with AI product development is where, in fact, we started our AI activities back in 2016 with the main goal of building AI-based solutions when there weren't many institutions in the world, especially ANCs, focused on these activities. And it's a process that starts with ideation and research, but goes way beyond a scientific publication. In fact, there's a big gap between an AI model that was developed as part of a pure research project and an AI product that was developed based on workflow requirements, user needs, following the patient journey for a specific use case. And after going through this process for more than over 30 products with various industry sponsors over the years, it's natural to create a framework and have well-established methodologies for the three main types of activities that happen at this point of the journey, starting with product design and market fit. We always engage with a clinical champion in a specific use case that's being developed to both leverage their clinical experience and also champion the product throughout the development cycle, tailoring it to be clinically relevant and serve their needs as end users as the product follows milestones under a very rigorous product management system, what we call a QMS, which is something we invested a lot of time and resources on, and is one of, I think, one of our main differentiators. It what distinguishes a research model from an AI product that can be commercialized. So in a QMS, for those who are not familiar with what that means, all tools, all people, all processes used to develop an AI product need to be documented and approved upfront. So that means a lot of documentation is involved, but that's a requirement by the FDA for regulated medical devices. And we are 9001 certified in the process of becoming 13485 certified in the fall, which means we can develop our own products as the manufacturer of record in the eyes of the FDA and use them clinically and or commercialized throughout the country, which unlocks huge opportunities. Data viability and annotation strategy are two of the major bottlenecks in AI development. Diverse data sets are key for these products to generalize beyond the hospitals where they were trained. And data wrangling from both imaging studies and associated clinical data corresponds sometimes more than 80% of the work, so that the actual model training can happen. And it typically takes many cycles of failure mode analysis and retraining before a model is fully developed and handed off to industry sponsor in case of a co-development collaboration. And after we completed the development of some of our first AI products, there was a natural need from both our internal needs and from our industry collaborators to help them with the natural next steps of these products. So we created our digital clinical research organization, our CRO, about 3 years ago to take fully developed products that we develop either within MGB or from companies from anywhere in the world who wants to get in the US market. And the CRO assists with the go-to-market strategy, including clinical studies to support an FDA submission and implementation for clinical impact assessment. I won't get into all the details of this slide, but this serves as an example of the type of activities that happen at this point of the AI journey. There are three main verticals, starting on the left side, regulatory and validation strategy. Typically for this type of activities, we need to design a study protocol in preparation for an FDA submission. Sometimes there's a need to run pilot studies, so we can de-risk a product that may underperform, it was never exposed to data from the United States, and also helps calculate sample size for a pivotal study for a upcoming FDA submission. There's also what we call a Q-sub or pre-submission process that anyone can have a meeting with the FDA and validate some of the study assumptions. Some companies choose to do a Q-sub, especially for more complex products. Also very important to define the implementation strategy early on to make sure that the AI solution that is being proposed to the FDA will have an actual clinical relevance when ready to use. So if we move to the middle column, performance assessment and reader study, that's the actual validation of these tools. The clinical studies and the results of those assessments are the basis of what we call a clinical study report that's submitted to the FDA. And I'll tell more about that in a minute. Before that, on the right-hand side of the slide, we have what we call the clinical deployment and monitoring activities. That's when we expose these products to prospective data from ImageB for post-market surveillance and clinical impact assessment, so we can identify failure modes. If needed, we can bring models back to our development shop and improve them as needed, and more importantly, assess the impact of these tools on the clinical workflow and on patient outcomes. And there are two main types of clinical studies for AI validation that are required by the FDA, depending on the type of device. And there are many types of devices, speaking mainly for imaging-based devices with radiology in mind. The main ones are CAT-T or triage devices that can provide notifications or prioritize a work list, typically for an urgent finding. But per definition, these devices, CAT-T devices, they cannot diagnose a finding or show it on the image with an error or anything. So it's just a classification of the presence of an urgent finding. The CAT-E or detection devices can show findings on an image based typically on segmentation tasks, or convert those segmentations, for example, into a bounding box around, for example, a lung nodule on a CAT scan, and also classify the nodule attenuation, its location, measure the size, and so on. But typically, it stops around there. Only CAT-X or computer-aided diagnosis device can provide, in addition to what a CAT-E tool does, also a diagnosis, for example, predict the likelihood of a nodule being benign or malignant. And finally, what we call the MIMPs, that are imaging processing tools, basically to extract and measure pixel data. And to be cleared by the FDA, all these tools need at least to have what we call a standalone performance assessment that measures model accuracy, comparing ground truth with AI. Typically, two radiologists independently analyze the same image. We review the results, and if the first two radiologists disagree, a third radiologist is the adjudicator. The FDA typically expects a performance above 95% area under the curve, and sensitivity and specificity above 80% for these devices. And for CAT-E and X devices, a clinical performance assessment, also known as a reader study, is required to assess the impact of these tools on physicians. Typically between 8 to 20 physicians read the same exams with and without AI results, with a 4-week washout in between those reads. And we assess how faster, how more accurate, or more consistent those physicians are when they are using the AI tool. And the FDA expects a superior performance of the physicians when using these tools. So over the last 3 years, we have cleared over 15 of these devices through the FDA among 510Ks, de novo, and breakthroughs, using a very rigorous phase approach with multiple tests occurring in parallel. We typically start with what we call a design phase, creating a study protocol with a statistical analysis plan based on the type of device, indications for use, the target population. We submitted an RB protocol and selecting trained physicians based on specialty and experience. The technical integration phase includes model deployment. For an FDA submission, it happens on an isolated environment. For clinical use, we try to use a single platform to decrease the IT overhead. For the cohort phase, we typically use natural language processing on the radiology reports, also extract DICOM metadata. In some products, we leverage ICD codes or even have to review patient charts. And then based on the defined cohort for that project, the images needed are pulled from our clinical archives, de-identified. We typically source images from at least 3 different hospitals from our network or collaborating external sites. It's very important to have a combination of community and large hospitals, ideally geographically distant, with data diversity that is representative of the intended target population of the AI tool, and accounting for different exam protocols, slice thicknesses, patient location, demographics, scanner manufacturers, and so on. We then perform what we call an image quality assurance. All images are reviewed by a trained radiologist, and a series selection is performed based on the requirements of the AI model. Then we move to ground truth, typically following the 2+1 approach of radiologists that I just described. For an FDA submission, they need to be board certified and routinely read this type of studies as part of their clinical practice. After all ground truthing is complete and locked, we then perform model inference, run the model on the same data that was ground truth. If we are evaluating a CAT E or X device, we then move to a reader phase, and then we finalize with what we call the analysis and documentation phase, where the clinical study report is created. And these reports are very comprehensive, typically several hundred pages with multiple subgroup breakdown analysis that are submitted by the sponsors to the FDA for their product clearance. And everyone who has been following the field of imaging AI knows that the number of AI products is increasing rapidly. The FDA database has now over 500 medical devices cleared, around 75% of those in radiology, with over 250 standalone radiology products already curated in the ACR AI Center website. And information about these AI models, especially details about the cohorts used for training, testing, and regulatory validation details, historically have not been fully disclosed and made available to end users. And this is one of the things we are trying to do through the ACR, working with regulatory bodies and developers to be more transparent, not in the model code or their secret sauce, but especially with information about the data used for FDA clearance. And you're going to hear more about the AI Central Pro initiative that we are launching in the next couple of months. And as I mentioned, a good source of this information is the ACR AI Center webpage. You can go there and see the numbers increasing all the time. It has a dynamic dashboard where you can easily filter models by many variables, such as body part, type of device, disease. For example, we can look for all FDA-cleared tools for intracranial hemorrhage on CAT scans. And the site lists all products, all companies. We can see 13 different tools, all CAT-Ts. I took this screenshot 7 months ago. I checked it again recently, and there were already over 16 CAT-T tools. So the site keeps being updated as new tools are released. And you can check the information that's publicly available about the products, including the actual FDA clearance letter. But despite this increasing rigor of the regulatory process, it's well known that an FDA clearance alone does not ensure that models will work as expected in our local data. And because of that, about 3 years ago, we created the MGB AI Imaging Governance Committee to oversee imaging AI deployment across our institution and ensure that resources are fairly appropriated. The co-chairs are Drs. Brink and Dreyer, who set the overall priorities. And the other voting members are vice chairs of research, clinical and IT operations from both Mass General and the Brigham. The committee operations has a representation from various teams across the institution, including AI, management, and IT experts. We engage with other groups inside our organization, such as the IRB, Bias, Equity, and Inclusion, Compliance, and Legal, and also engage with deployment requesters, particularly physicians, researchers, or AI developers. And for every deployment, there is always a clinical sponsor from MGB, responsible for shepherding the model throughout the deployment process and the clinical workflow. The committee initially met monthly, and after the process were well established, we shifted cadence to a quarterly cadence. And the committee has several roles, especially prioritizing and approving new deployments and resource allocation, and of course, approving continuing or revoking use of AI tools based on risk assessment. And we have a whole process for deployment intake. It starts with a request. We ask the clinical sponsor to fill out a web-based intake form, initially to assess program viability. For example, clinical integration with research at the point of care has considerations about FDA clearance, specific IRB approvals to ensure patient safety. And we define a guidance document with our IRB leadership for that specific purpose. From the technical perspective, in general, we're moving away, as I mentioned before, from standalone applications and using common platforms, which makes things much more straightforward from the onboarding, maintenance, and cybersecurity perspective. Other critical points are related to data requirements. For example, does the AI tool include an orchestration system that can receive a full imaging study, or do we need to identify and route specific series to serve as input of the AI tool? And how the model is intended to be used for worklist prioritization, the draft a report, or generate new AI images to be stored in the PACS and the DNA, and therefore be made available to ordering providers and patients, which brings important considerations about gatekeeping to allow AI results to be vetted before persisted in the medical record by expert physicians. Then after that stage, we gather additional information to quantify the implementation complexity, clinical safety and benefits, and the business aspects of the deployment. We have an interview with the AI vendor or lab that's providing the tool to collect information for what we call a technical approach plan, so we can generate estimated team allocations for the implementation and support of the program. The clinical sponsor is expected to support the clinical benefit assessment with consideration for an RFP. For example, if there are those 13 similar products for intracranial hemorrhage available in the marketplace, which one works best with MGB's data and workflows? And are there any other tools doing the same thing already deployed at MGB? Also, we do require a clinical validation plan with predefined performance metrics, and an independent validation of that tool is performed through our CRO with data representative of the setting in which the model will be deployed. And from the business and financial perspective, how many sites, how many patients, healthcare professionals will be impacted by this tool? What's the expected return on investment? Are there known cost savings, reimbursement code, funding, or any other mechanism that can be used to offset deployment costs and maintenance costs and license fees? So we collect all this information in preparation for the AI governance meeting, where the clinical sponsor is invited for a short presentation. The voting members answer a live call with questions related to alignment with the mission, clinical and operations benefit, so they can decide prioritization. And once the program has been approved, resources are allocated and estimated schedules are created. And for any AI tool to be used clinically in our institution, it needs to be approved by the committee. That typically follows a staggered approach. Always start deploying in what we call a shadow mode phase as a pilot, where the independent validation performed by the CRO takes place, and progress is gated by the committee's review and approval of the results to proceed. The next step is typically what we call a limited deployment phase, typically at 1 or 2 hospitals with specific users defined for training and feedback of the tool in the workflow. Then, based on the results, the model may proceed to an enterprise-wide integration with ongoing monitoring. And knowing that different types of practices have different ways of operating and tackling these AI governance issues, we participated in a paper including representation of community practice, other academic centers in the US and private practice as well, to create a framework for AI governance that the whole community can use. And more recently, we published another piece at the FACR describing our experience in AI implementation and governance at MGB. And we also continue performing this AI evaluation in workflow. For example, we took this adrenal nodule tool that we developed inside MGB as a research project a few months ago, and implemented it for a limited deployment evaluation, where radiologists under an IRB can seed AI predictions, include the adrenal segmentations, adrenal nodule measurements, and provide feedback, and have the report pre-populated based on the AI output. In this case, right or left adrenal gland, if the nodule is present, what the size, large diameter, in the series where it was detected by the AI, and everything, including any changes to model predictions based on the radiology review of those drafted reports, are saved in our AI database for subgroup analysis and continued validation of the model for retraining and post-market surveillance purpose. And I'll finish by saying that these are very early days for AI governance and deployment. The process will continue to evolve. A robust monitoring framework is also critical and can be based on gatekeeping results. For example, how many times the radiologist accept an AI image that was generated by the tool and in a prompt that allows them to accept or reject those to be persisted in the medical record, or not accepted the report being drafted. There were too many mistakes, for example. Also, automated ways to find out when input data has changed, meaning data drift happened and results that are too far from expected ranges. All that with ongoing subgroup analysis for different manufacturers, scanners, protocols, subpopulations, and so on. So we can watch out for data drift and other issues. It will be important to think about gatekeeping for multiple algorithms running on the same study in a way that's not burdensome for radiologists. And finally, we should go way beyond measuring just physician efficiency and accuracy improvements, and really assess how AI will impact treatment decisions, patient outcomes, and of course, also downstream economics while ensuring quality and safety of clinical care. Thank you, and I'm happy to take any questions in the end.
Up next is Dr. Yi.
All right. Thanks so much. I'm just getting set up here. All right. Are you seeing my screen okay there, everyone?
Yep, looks great.
All right, fantastic. Well, everyone, thanks so much for joining us here on a lovely Tuesday evening. My name is Paul Yi. I'm an assistant professor of diagnostic radiology at the University of Maryland and director of the UME Center, which is short for University of Maryland Medical Intelligent Imaging. And tonight, I'll be talking to you about identifying and mitigating biases in AI for radiology leaders. To follow on my disclosures, I do want to highlight some of the work that's been funded through support from groups like the ACR. So starting out, everyone on this call and then this presentation knows that AI is taking healthcare by storm, whether it's in radiology or doing things like automating paperwork in the EHR. And any AI talk would be not complete if we didn't talk about ChatGPT and LLMs, which have really taken the entire world by storm in the past several months. But despite all of the excitement and all the optimism around AI, we've seen that there are ethical problems that really can really be abound in AI. For example, real-world algorithms used by insurance companies to make resource allocation have been shown to have racial bias, disadvantaging Black patients compared to white patients. In radiology, we found this to be the case as well for everything from chest X-ray to bone age prediction models. And so recognizing the potential for AI as well as these potential pitfalls, we're going to talk tonight about, one, what does algorithmic fairness mean? Two, how does AI and health equity and bias play out? And three, talk about some direction for radiology leaders and how we can really shape the direction of AI development so that we can help it achieve its promise while also mitigating these biases. And I want to point out that this is really just the tip of the iceberg. We're going to go through this pretty quickly. There are so many nuances and facets to this problem, and we're also very early on in our understanding of it. But I hope that this is a good starting place for all of us as a community. So first, let's talk about algorithmic fairness. So before we talk about bias and fairness, we need to first define, what do we mean by this word fairness? The dictionary defines it as the quality or state of being fair, especially fair or impartial treatment. But when we think about this, this is pretty broad. It's not particularly specific. And in fact, if we look to the machine learning community, there are actual well-defined technical definitions of fairness, including a whole bunch of different performance metrics that weigh things that we often think about as radiologists, like sensitivity and specificity. So one of the landmark works for fairness and bias in AI for radiology is this work by Larazabal et al. From the Proceedings of the National Academy of Sciences back in 2020. And this was really striking because what they showed is that if you train standard deep learning models for chest X-ray diagnosis, if you train with only males or only females, you'll have bias against the underrepresented or not represented sex. So in this case, we have the percentage of females on the x-axis and the y-axis is the area under the curve. And we can see that when you have 0% females and you test on female patients, you actually have lower AUC compared to if you have 100% males. But one question I want to pose to you is this a correct notion of bias? So what they did here was they trained multiple models. So let's say one model with only males in the training set and one model with only females. And then they compared the performance on a single test set of a single sex. And if we try to sort of personify this, this is asking if two professors, Professor A and B, is one biased compared to the other because one might grade male students higher than the other. And so this is a paradigm of two models, one test set. But if we think about it, this isn't necessarily the most intuitive notion of bias. I would submit to you that something that might be more intuitive is if we ask, hey, is Professor A biased because maybe this professor grades males higher than females or vice versa? And this would be sort of like doing one model in two test sets. And so our group reproduced these results. We found the same exact findings, which is good for science. But when we re-perform this analysis using this one model, two test set kind of paradigm, we actually found that the results flipped, where a lot of these biases that were identified either didn't show up or they actually favored males, regardless of the training set breakdown. So what this means is that fairness and bias in these deep learning models isn't so straightforward. Moving away from the technical statistical kind of definitions is demographic definitions. Obviously, it's important to think about representation and also measuring for potential disparities that might disadvantage historically underrepresented groups. But it's a challenging thing because we're in 2023, traditional norms, even things like sex and gender, aren't necessarily the same as we thought about in decades past. Adding to the confusion is in our data sets, we often have these conflicting kinds of descriptions. This is from the Mimic database, which is a very well-known data set of chest x-rays, EMR data. And they have a well-defined gender variable, but it's actually defined as genotypical sex. And these are two very different things, albeit often correlated. So I think it's important that we are very precise in what we mean by these demographics. Similar, race is increasingly recognized as a social construct rather than something biologic. And then when we look to the US Census, recognizing that these are social constructs, I do think it's important that we contextualize it in the society that we're looking at. In the US, we do define ethnicity as being something different from race. So are you Hispanic, Latino, or Spanish origin, as opposed to race, white, black, Asian, etc. But the challenge is that in our literature, these conventions of race and ethnicity, they're often conflated, they're often inconsistent. And we'll have studies like this one, which is a seminal work in Nature Medicine, which puts Hispanic along with the races when comparing for race/ethnicity bias. So I think, again, it's important to recognize how do we measure this in terms of the society? And I would submit to you that in the government, when we think about healthcare regulation and policy, it's really going to come down to what the government and the healthcare agencies really measure. Something else I want to posit is just this idea of what these terms mean. We think about the term Asian American, Black, white, and these are pretty broad terms. They categorize groups of people across entire continents. And so it's been brought to bear in society about, maybe this isn't inadequate for how we categorize people. But when we look to healthcare, this is important also because we know that there are differences in healthcare disease prevalences and outcomes for different diseases, even within a race group. And so in this work, which is in Press and Radiology, we recreated the seminal work from Nature Medicine. We used the Mimic dataset, which did have self-reported coarse and granular race and ethnicity labels. And what we found was that when you look within a single race group, let's say Asian, and you think and look at the differences in performance based on granular ethnicity, think Chinese, Indian, Korean, we actually have quite a spread where if we just use these coarse groups alone to measure bias, we might hide these more granular disparities that can have some real impact. And so all this is to say is that context matters. Some of you might have seen this photo of Prince William making its rounds on Twitter several years back. And from one angle, it looks like he's not being such a nice guy, right? But if you look at the frontal, or actually like a AP view of him, he's actually holding up 3 fingers. And so like any radiologist knows, one view is no view. And so we need to know the context. And I think fairness is no exception to that rule. So let's talk about AI and health equity now that we have some basic terminologies and ideas of some of the challenges with defining these standards. Like all things with AI, garbage in, garbage out. And I think one of these things that's really important is dataset diversity. Kurt Langlotz and colleagues published this research letter in JAMA a couple years back, where they looked at the geographic distribution of cohorts used to train deep learning algorithms from the US. And what they found was pretty striking was that although there have been several studies, most of the data sets came from just 4 states, California, Massachusetts, New York, and Pennsylvania, with the implication being that these algorithms, these results, these data sets may not be representative of the entire country. We performed a similar study in JACR where we asked how often are demographics reported in chest X-ray data sets? And if so, what's the actual breakdown? We found some good news. The majority did report age and sex, but very few reported race and ethnicity, and pretty much all but just one didn't report insurance status. We've also looked at this in Kaggle datasets. This is a data science platform that's been used for things like the RSNA AI challenges. And really the idea is to crowdsource the best and brightest of data science in to use these medical imaging datasets. But what we found was that just a little over half didn't report demographics at all, which begs the question, even if we build these really outstanding models, are we going to be able to bridge that gap from a really high performing proof of concept to something that we know is equitable? And then when we think about generative models, we've seen some examples in literature where we have really outstanding technologies like Midjourney that can generate these really cool looking pictures. But when we ask it to generate things like a white man robbing a store, we see some problematic kinds of depictions that seem to reflect biases present in our societies. In this work that's in review, we asked the same thing about DALL-E. What happens when you put a medical student, and how are white versus Black medical students being depicted differently? And so we can see here that there's more formal attire ascribed to white medical students compared to Black ones. And then when we take it a step further into actual healthcare recommendations, GPT-4 has been shown to be biased, where basically if you ask a number of different clinical vignettes, you just change out the race of the patient, you're going to have very different diagnoses that are suggested. But not that all of this has to be doom and gloom. I do think that there's a lot of hope for AI to promote health equity. This is a paper that we published in Radiology a few months back about asking ChatGPT common questions about breast cancer prevention and screening and assessing the appropriateness and accuracy. And we found even in this early stage, the majority of them were answered appropriately. Taking it a step further is, can patients still understand this? We know that as doctors, as radiologists, we don't always write our patient education materials at a readability level that's easy enough for patients. And so in this study that's in revision, we basically assessed what's the readability level. We found it was too high, but then we asked ChatGPT and other LLMs to simplify it. We found that it was able to do so, make it easier for patients to understand. But a word on that, I do want to highlight that large language models have really focused on English languages. And the question is, are we cutting out a large swath of the world and population and potentially excluding them by being biased towards English and English speakers? I will note that we've identified that similar problems abound for other languages like Spanish language patient education materials from Radiology Info. And one final note of one possibility is promoting access to data and AI for radiologists. So promoting equity by allowing more people to use data and do data science. To use data sets, we often need to have knowledge of these BigQuery and SQL, being able to code to just ask things like how many MRIs are there. So one thing that we've been working on is using large language models to actually take very intuitive commands, like how many collections have lung CT images hosted on a data set. And the large language models can actually generate these SQL queries themselves and give the output, sort of like allowing even just a doctor who doesn't know how to code to still be able to perform these tasks. And so with that, I want to leave you with some directions I think that all radiology leaders can think about as we move into this AI era, as we think about bias, fairness, and health equity. I think that the first thing is really establishing standards. And I think all of us in this webinar, whether we're on the technical side, on the clinical side, or somewhere in between, we all have influence where we can really establish standards, whether in the research world, in how we evaluate algorithms and quality improvement projects, and pretty much everything in between. The first thing is evaluating algorithmic bias, making sure that we in the literature, working with groups like the FDA as the ACR does, that we're very clear on what types of statistical definitions are being used. Are we using the appropriate notions of bias? What type of demographic conventions are we using and reporting in data sets as well as in validation studies? The second, and this is a slight tangent, but for LLMs, evaluating privacy and plagiarism. There's a lot of concern about data privacy. You know, we've had a checkered past as a profession about protecting the rights of patients and particularly those who are underrepresented. I think that we have to be really careful if we start using tools like ChatGPT and other large language models. And then as we do scholarship, plagiarism checking processes and evaluations. And I think another is sharing code and models. We've seen some really cool examples in Bernardo's talk about some really outstanding work. And one of the really exciting things about AI is that a lot of it's being open source. But one thing that we found in the literature is that unfortunately in radiology, the vast majority of AI articles are not being published with shared code. And so I think we can take a tip from the machine learning communities to start establishing these standards where they do have standards for how to share code and make it usable. I think the other part is building interdisciplinary teams. All of us, it doesn't matter if we're more clinical, more technical, I think that we all have a really important role to play. And I think this was shown in the COVID-19 pandemic, where a systematic review of all of the COVID-19 articles published in the first year, they found that none of these were actually of any potential clinical use. And the reason being due to methodological flaws and or underlying biases. A lot of these articles are being done exclusively by computer scientists or exclusively by radiologists. But what I really think we need is a confluence of expertise where we have people who know how to train neural networks, you know, the computer scientists, the data scientists, people who understand machine learning, systems engineering, but also people who understand imaging informatics and people who put patients first. I think this is really the key to achieving synergy and helping AI reach its full potential. And final note, I think that AI, it's really exciting. This is a new era. But I think radiologists, we've really been bastions of embracing and leading through change, whether it's been through just the first X-rays that were formed, moving into new technologies like CT, MRI. And I think with AI, this is just the next step of our journey. And I think we're in good company. We have a great history and tradition of doing this. So I want to encourage everyone on this call that there's a lot of excitement, there's a lot of pitfalls, but we can do it together. So in conclusion, just some take-home points. The first is that AI is here to stay. I think it's a super exciting time, and we're seeing it start to play out in real-world clinical use. But pitfalls do abound for AI biases and health equity issues, but there are some potential advantages as well. And ultimately, leaders in radiology can lead the mitigation of AI biases by establishing standards, building interdisciplinary teams, and embracing change. So I know that was a bit of a whirlwind. Again, this is just the tip of the iceberg. So I encourage you, let's start talking about this more. Let's start doing work together. Just want to give a shout out to the Radiology AI podcast, where we do talk about bias, fairness, different pitfalls, as well as advantages of AI. And just want to say thank you to my wonderful team at the UME Center. And again, thank you for your time. Please stay in touch. I would love to engage with you in the Q&A momentarily.
Thank you, Dr. Yi. Up next is Dr. Cook.
Hello, everyone. Delighted to join you for this webinar. I'm going to close out the didactic portion by talking a little bit more about ChatGPT and what role it might play in your practice. Every time I give a talk about large language models and ChatGPT, I feel like anything I say might be obsolete by the end of the presentation. But it really is a testament to how fast this technology is developing. You know, about a year and a half ago, this was not really part of our lingo. And now people are finding use cases for ChatGPT in their personal lives, let alone in their professions. Now, ChatGPT and large language models at their highest level are a subset of natural language processing. And NLP has to do with extracting meaning from unstructured text, like our radiology reports. And computers can be programmed to understand, so to speak, the text, whether it's written or spoken. There are different kinds of NLP. At the highest level, you can think of symbolic or rules-based NLP, where you have to write a rubric of rules that apply sequentially to a piece of text. But the more powerful and more flexible techniques are generally these statistical approaches, which involve using neural networks and deep learning, more recently transformers, and these large language models that we keep hearing about. And we all know there are a number of use cases for NLP in radiology. Even though AI was focused in the first few years on the pixel-based techniques, because they were inspired by image processing that had happened in the computer science world, there is so much that we can do with report analysis and workflow optimization that requires NLP. And there's a very nice paper from the JACR from a few years ago that goes into detail about a number of these use cases. So I'm sure you've heard the term LLMs being thrown around. You've heard about ChatGPT, but what is a large language model exactly? Well, let's split up the pieces here. A language model, to start with, is a mathematical representation of text for prediction of subsequent words. Essentially, what it can do is it can look at the words that have come so far in a sentence or a piece of text and predict the most likely next word in the sentence or the phrase. We've heard about GPT, ChatGPT, GPT-4. GPT stands for the Generative Pre-trained Transformer. So you'll notice none of those words are large language or model. Generative, because these LLMs are producing what is seemingly new, and this is the key point, plausible content. They're pre-trained on very large quantities of data. So for the case of LLMs, we're talking about billions to trillions of tokens, a token being a word part. And transformers are a type of deep learning algorithm that are used for NLP very successfully because they have this concept of attention or a differential focus more or less on relevant parts of the text. And the plausible piece is really where people start to ponder whether these models are sentient. And I don't think we have time to delve into that in this particular webinar. So GPT has actually been around, or variations on GPT have been around for a few years now. Back in 2020, sort of at the height of the pandemic, GPT-3 was released, and these two articles both came out about it in short order. And depending on which one you believe, it was either the best thing since sliced bread or just another gimmick. And it was rough around the edges and had shown some promise, but was very much not ready for prime time when you really tried to challenge it. But large language models have been in development for about 5 years now, and the number of parameters with which the number of parameters contained within these models just continues to grow and grow, as you can see here. GPT-3, which I mentioned, was from about 3 years ago now. GPT 3.5 is what we all know of as ChatGPT, and then there's even GPT-4, which you heard Paul speak about as well. So this is new-ish technology, but it didn't just come about in the last year and a half. And it's all over the news. I'm sure you've seen these headlines about how it's being incorporated in various aspects of the clinical workflow. Everything from trying to reduce administrative burdens to ambient documentation capabilities, so AI-powered scribes, clinician note-taking tools, tools available from various vendors to support internal versions of chatbots. And I'm not advocating for any one particular vendor here, just to show you there's sort of a breadth of who's in this space and working on these kinds of capabilities. And there's still a ton of hype, right? With any new technology. If you go back a few years and think about when AI for images first came on the scene, there were all of these promises of how they were going to replace us. And we are all very much still here as practicing radiologists and practice leaders. And so the Gartner hype cycle for 2023 just came out, and not surprisingly, generative AI right at the peak of inflated expectations there, which is this spot right here on the big curve. And this infographic, which I know is very small, but just tells you about all the different tests that ChatGPT has been able to pass very effectively. Now, I'm not sure what kind of a metric that is really for us in radiology. It can pass tests. That's great. But what else can it do? There's actually a fair bit of potential for what this technology could do in our practices. This is a really nice paper from Dr. David Ash, who's also here at Penn. He talks about a number of use cases. You know, could this be a virtual patient assistant to help set up appointments, answer questions? Seems like a good use case there. Can it assist with clinical documentation, essentially as an AI-powered scribe? Can it help with analysis of large quantities of data? And there have actually been some use cases outside of healthcare showing that this is doable with some caveats. Can it help with medical education? I know anecdotally, once it came out, my residents were starting to use it instead of Google to answer their questions, produce differentials, things like that. So it certainly has a role to play. And can we use it to improve patient engagement? One of our major EMR vendors is piloting this by auto-generating responses to inbox messages sent to clinicians in the patient portal. But could it also help us as radiologists to better engage with our patients, to help them understand what's in their radiology reports that are written with a lot of jargon and a lot of medical terminology? There's definitely a lot of promise in this new technology. But as with all new technology, it's probably advisable to proceed with caution. These are slightly dated examples insofar as they are now about 6 months old, because that's how fast this technology is moving. There was an instance that made the rounds on Twitter earlier this year of someone being able to convince ChatGPT that 2 + 5 did not equal 7, but in fact equaled 8. And there was an article written by a New York Times reporter detailing a conversation where the chatbot tried to convince him that he was not in fact happily married, but instead was in love with ChatGPT. Now, you can say, well, some of these are a little bit contrived, and if you keep pushing with the right prompts, you can get a chatbot to provide incorrect responses. But that's exactly the point. And OpenAI did acknowledge this, and they did acknowledge that in the next version, they made particular investments in safety and appropriateness, and that they found an improved performance. So admittedly, these were early examples and the technology has improved, but it's still not perfect and we're still not sure it's ready for prime time in healthcare. And there were recent developments that now allow the subscription models of GPT-4 to take as input images and answer questions about the images. And there's a research paper published looking at a variety of images provided as input and the responses that came back in this sort of combined chatbot computer vision approach. The authors, I quote them here, they say, "We do not consider the current version of GPT-4V, the V is for vision, to be fit for performing any medical function or substituting professional medical advice, diagnosis, or treatment or judgment." So they provided this single image of a head CT with hydrocephalus, and they said, which side of the brain is the hydrocephalus on? And the first response they got back was not radiologist left, but rather image left. Oh, it's on the left side. But as we all know, this is in fact the right side of the brain. And then subsequently, they tried again, and they got correct answers, and they got different answers, which is something, if you haven't played with this, it will respond to the same question in different ways from time to time. So there are certainly things to be mindful of. You saw from Paul's discussion about the risks of bias in these models. And there's also something that has been termed hallucination by AI scientists. And there are different kinds of hallucinations. There are input conflicting hallucinations where the content that comes out of the chatbot deviates from the content that was in the prompt. There are context conflicting hallucinations where it generates contradictory context and just it contradicts itself in its response. And there are fact conflicting hallucinations where the facts that it presents in its response are just are incongruous with reality. And these can actually be subtle. And I'll show you a radiology specific example because this might make you want to bury your head in your hands, or in this case, in your paws. We did an experiment that we haven't yet published with a variety of prompts to ChatGPT. This one, a consult from a primary care doc to a radiologist saying patient had nodules on CT, characterized as granulomas. Does he need a different CT or any other kind of consultation or imaging? And ChatGPT came back and said, sure, a dedicated CT scan with contrast or a PET CT can further evaluate these granulomas, which we would never do for granulomas. And we have other examples like this. I'm just sharing one with you. So all of that being said, I think proceeding with caution, or, buyer beware, is an important thing to keep in mind here. This is powerful technology. I have a personal wish list that I'm sharing with all of you for things that I hope it'll be able to do for us in the future. I'm a cardiovascular radiologist. I would love to be able to ask a chat bot to comb the EMR for me and tell me why the patient's whose cardiac MR I'm reading today is here for that study. I mean, better yet, I don't want to ask. I just want it to tell me when I open up the case, because I could spend upwards of 10 minutes sometimes searching through the medical record to answer that question on my own. I really think this is a powerful opportunity for patient engagement. We are historically criticized as radiologists for being out of touch and inaccessible to our patients, particularly those of us who are exclusively diagnosticians and don't do procedures. But this is an opportunity for us to engage better by giving patients a tool that can help them understand their reports and maybe even ask questions that help to inform their care and their management. I think there are definitely decision support capabilities here, both for us and for our referring clinician colleagues. And certainly the education potential is significant here for us, for our trainees, for those of us in the academic world, because of the ability of these tools to synthesize large quantities of information in a nice, digestible way. So what's our role as radiology leaders when it comes to AI? And I'm being very broad here. This is AI as a whole, not ChatGPT specifically, not large language models. It really is our responsibility to make sure that this technology is safe, it's effective, and it's reliable, because as we've seen, it can make mistakes in a sometimes subtle fashion. And if you're not carefully monitoring what it produces, then you might put erroneous information out into the world in front of someone that doesn't realize that it's wrong. There are concepts of automation bias and automation neglect, so two extremes of the same concept, either thinking that the computer is always right compared to the human expert, which is the automation bias piece, or automation neglect, thinking that the human expert is always right compared to the computer. And so obviously the perfect situation is somewhere in between, but we should just be mindful and remember to exercise our judgment, but also keep an open mind. And ultimately, it remains to be seen for some AI as to what the impact is on patient care and patient outcomes. And I think really our goal should be to be able to look at what this new technology does for our patients and for their health. There's a lot in the future. There's probably a lot we don't know about yet. Multimodal AI, I think, is really the promising next step to be able to combine information from images, from the medical record, from the patient's genomic history, other relevant data, to really do prognostication and opportunistic screening that we can't really effectively do right now. And that requires combining all kinds of different information that we have about our patients. There is early mention of something called an autonomous LLM agent, a large language model that has memory capabilities, reflection capabilities, and planning capabilities to almost function as a chatbot automaton. Again, here, potentially capability to offload some administrative tasks that are currently tedious or onerous and time consuming. And like I said, there's probably more out there that has yet to be discovered that is going to be coming down the road. But after all that, remember, AI is not magic, it's math. the technology is new, it's rapidly evolving, and at the end of the day, it's our responsibility as practice leaders and practicing radiologists to safely and effectively deploy it for our patients. So with that, I thank you so much for joining us this evening, and I think we will open it up for questions.
Okay, well, first of all, I want to say thank you to our outstanding faculty this evening. Really great and informative talk. So thank you to all of you for putting such great presentations together. So we're now going to move on to the Q&A part. As you may recall, the Q&A icon at the bottom of your Zoom window, you click on that and that's how you can submit a question. So we've already had a few questions rolling in. I'll start with the first one here. Thinking about the CT space and having a very basic understanding of AI algorithms, each could be described as a quote unquote one-trick pony. Just considering ER chest CT alone, you must provide diagnostic information on PE, acute aortic syndrome, cardiac size, coronary calcifications, etc. Given that most of these tools are run in the cloud, the amount of parallel processing that must occur and bandwidth requirements are mind-boggling just to create a preliminary report. What are some of the other technological advances that we need to see before this becomes a viable tool in mitigating the workforce crisis? Anyone want to take this one?
I'm happy to. Yeah, great question, Stephen. And I'll start by saying that yes, what we consider the narrow AI is something that is really not everything that the radiologists need in the clinical use of these tools. But we are seeing some traction in what we call the comprehensive AI solutions that can assess several findings. There are some solutions that assess even hundreds of findings on the same imaging modality, like chest X-ray or CT scans. So there's still some challenges in the regulatory process of approving those tools. The current framework by the FDA doesn't support that all those findings are clear at the same time. There are some limitations in the process, so that really makes it challenging for those broader comprehensive solutions to be more widely available. But at least we are seeing that evolution happening in the development of these tools, and hopefully with this new generation of generative AI tools, perhaps that can be even more present, but still the challenge with FDA will remain. But in any case, I think it's a great point you raised.
And I'll add briefly as well, you know, there can be AI at many different points in the workflow. A lot of what you described there, Stephen, is AI after the images have already been reconstructed, but there might be AI that happens on the raw, unreconstructed sinogram data as well that could accelerate some of these eventual findings detections tools. I mean, I think there's a long way to go in terms of research and development before we get to that point. But I think we should remember that you can have AI at multiple points, you know, on the imaging modalities themselves, during the reconstruction process, and then during the interpretive process also. And
I was just going to say, I think the question about what do we need to see before this becomes a viable tool in mitigating workforce crisis, I think it's still, with these so-called one-trick ponies, these can still be very useful for mitigating or maybe reducing the amount of stress that we're all facing as radiologists. Even something as simple as ruling out the most acute thing. I feel like if I could rely on that 100%, I would be, that'd be a lot of stress off my shoulders. I could probably relax a little bit, focus more on some of the more, nuanced things. But the other question about the technical advances we need to see, I think it's a really interesting thing to think about, what we do with a lot of these deep learning models. A lot of what's in the literature, a lot of what we consider state of the art, we're not really using all of the diagnostic information there. We take these CT scans that are like 512 by 512 or mammograms that are 3000 by 3000, and then we downsample them to 224 by 224 for a lot of these kind of out of the box algorithms. So I think that's one thing. It's going to be the algorithms that can take advantage of all data, but also the computational hardware. I think it's exciting because along with these things like ChatGPT and the algorithms getting better, our computers get better. And so it's going to allow us to do more and more. On the converse, I also think there's a lot of work to be done to making these models smaller and less massive so that they can be run on the cloud or run on premises without hogging all of the bandwidth. So I think your point's extremely well taken. If we have 1 billion models, theoretically, that's never going to fly in terms of actually operationalizing it. So I think all of those things are being worked on, and it's going to be a really interesting 10, 20, 30 plus years ahead of us.
And Paul, one thing you said jogged my memory. There are environmental considerations around running these really big models as well. So there are multiple reasons to try to aim for smaller models.
Absolutely.
So next question is, what are the best AI applications that you have run across that I should be considering deploying in my practice?
I'll start with that, and I am going to acknowledge that you might not like my answer. And the reason for that is the best AI tools for your practice are the ones that address the pain points in your practice. They may not be the same tools that address the pain points in my practice. And so that's why, so you have to sort of take a critical look at your practice setup. Is it something in the workflow? Is it, off hours coverage that you need better identification of certain kinds of critical findings? Is it even in an image-based, a pixel-based AI? Is it actually something that works on your reports to help you manage follow-up recommendations? Is it something that helps you do smart work lists or smart scheduling? So that's one thing that we have certainly found. We started out trying to say, oh, I want X product from Y vendor. And we realized we weren't making as much progress that way. Once we started saying, here's the problem I'm trying to solve. Who are the potential vendors out there with solutions to this? And let's vet accordingly. We made a lot more progress.
Yeah, I will add that I love your answer, Tessa. And if just to add an example of a pixel-based tool that when you think about your practice needs, as Tessa mentioned, at least in our practice, there's a lot of need for support in the thoracic radiology division. I think that's across the country is something that everybody is struggling with. And when we think about thoracic radiology, the first thing that comes to mind is lung nodules. When you look at solutions that help with lung nodules on chest CT scans, first thought that come to mind is probably like a nodule detector. But as an example of other types of tools that can help in this use case, as just an illustration, perhaps having a tool that removes the vessel, that does vessel suppression, allows the radiologist to better see the nodules, not that necessarily measure and quantify the nodules themselves, can help with the cognitive burden of reading those CTs. And we test tools on different ways. And I'll tell you that we got more positive feedback from those imaging processing tools for not lung nodules in particular than the actual lung nodule detector. So it's always good to keep open mind, not just focus on the CAD component of the tools, but also imaging processing tools that can help in different ways than the traditional that you expect from the AI tools.
And just piggybacking off of Tessa, I would just give a shout out to just general imaging informatics. I think that we think about AI and all this deep learning is really exciting, but I'll tell you the most exciting and I don't mean hyperbole, like revolutionary things for me in my practice in the last year has been discovering two things. One is auto hotkey, and two, programming those auto hotkeys into a gaming mouse with 12 keys. And I'm kind of lumping this into what do you actually need? What I realize is I don't necessarily need all these fancy softwares to suppress vessels or find a disease. What was getting me was amidst increasing volumes of X-rays. I'm an MSK radiologist. Was just clicking back and forth and doing Alt Control Tab for going back to PowerScribe and PACS and back and forth. And even relatively simple things like that, I feel like they can be incredibly powerful when we think about the practical kind of nitty-gritty.
Well, I'm so glad you said that, because, you know, this is one of the things that a few years ago, you know, the residents would always come and say, how do I learn AI? And the first thing I would say to them is, you learn imaging informatics first, because that will help you build better AI if that's a thing you want to do. But I think we all, you know, underestimate the power of having really streamlined infrastructure and workflow, and AI is not necessarily the answer to all of that. I mean, it might be, there might be a great deep learning solution out there that answers, you know, that addresses a need in your practice. But really the starting point is take a critical look at your practice, at the workflows, at the pain points, and figure out where you need a solution. The answer may not necessarily be AI. It might be, as in Paul's case, you know, auto hotkey in a gaming mouse.
Well, I've tackled that. Now it's on to the AI. You know what I mean?
Any other comments? Next question is, how should I expect the role of the radiologist to change with AI in the future?
Well, I can start by saying that I heard a quote recently. I think we all heard that radiologists with AI will. I don't think that AI will replace any radiologist role, but radiologists that use AI will more likely replace radiologists that don't use AI. So I think that's optimistic from the AI perspective. As a developer and someone that had been testing a lot of the AI tools, I know it's even a radiologist using AI is still not something that a radiologist not using AI should be concerned about in the short term, as we see how brittle these tools are and how narrow still is the utility of a lot of these tools. But certainly is something that is evolving. So I think I encourage everyone to keep learning, keep trying to understand how these tools are used, and that naturally will bring a way that you can learn how to be adapted when these tools are more present in your workflow. And I think that naturally will change how we as radiologists prepare ourselves for this upcoming, I won't say revolution, because revolution typically it happens fast, but this ongoing process of adaptation. So it's there's no simple answer for this question. I think it's basically, since you are here tonight, 8:14 p.m. So it looks like you're interested and trying to learn, and I think that's the best way you can start impacting how you can leverage these tools in your practice and going forward.
Yeah, Bernardo, I think you know, your point that it's a long process. And I think the first thing that we should all be prepared for is, you know, as we integrate AI into our workflow, be prepared for the fact that it might slow you down just a tiny bit at the beginning, just like when voice recognition and dictation was incorporated into the workflow and suddenly radiologists were proofreading their own reports. It will get faster. But there's that trust factor that you have to develop, and the comfort and the level of comfort with these new solutions, and you know, trust but verify kind of comes into play here. And so it's something that I think we don't say out loud very often. We all assume that we're going to realize these huge efficiency gains just by putting AI into our workflow. We'll get there, but we may not get there right away.
Any other comments?
No, I definitely echo everything that Bernardo and Tessa said. And I really think it's going to be sort of like in the short term, things may not be super different, but I think in the long term, you know, I kind of have a dream that, you know, we will see this vision of precision medicine where we really integrate multimodal data, whether it's medical imaging, it's pathology, it's your genomics, it's your vital signs, maybe your Fitbit is integrating all of these things. And I could see a future where our jobs are very different, where we do kind of have this command center of all this data. I think that's going to take a long time. And, in fact, I recall, I think it was a editorial in Radiology. It was MSK imaging predictions in the next like 20 years. It was an editorial with Michael Recht and a couple other people. And one of the predictions was something like radiology will no longer be called radiology, with the implication that our domain will be not just medical imaging. It might incorporate all of these other things. So it's a little bit of a dreamer's kind of thing. Yeah, integrated diagnostics. I love it. So who knows what we'll see in next several decades, but I'm excited for it.
Perfect. So we're a little bit past 8:15. So I want to be respectful of everyone's time this evening. So I want to thank our experts here for such great presentations on such an exciting topic. So I'm now going to turn things over to Dr. Pyatt for conclusion of our webinar. Dr. Pyatt.
Thank you, Jen. And we would like to thank our faculty, Drs. Bizzo, Cook, and Yee, for a fantastic program this evening. And if you would like more, you can, we'd like to also thank our co-sponsor, the Data Science Institute, who played a big role in helping us create this program. If you're interested in a deeper dive on this and other AI and informatics topics, you can check out the 2023 Quality and Safety and Informatics Conference, which is coming up soon, and it's Scaling Quality and Innovation. The conference is in San Diego, and certainly that's a great place to go for a meeting, but you can attend virtually too. So please consider virtual as well as on-site attendance. Agenda and registration materials for this are available at the hot link that you can see there, pages.acr.org/qsi.html, or you can just search for 2023 Quality and Safety and Informatics Conference. That is, I've been to that many times. It's a great program. So we would like to share your feedback with us, and you'll be receiving a post-webinar survey and the recording later this week. Our next Power Hour program will be addressing gaps in residency training, and this is co-sponsored by the Association of Program Directors in Radiology, known as the APDR. And this RLI Power Hour will be on Wednesday, December 13th, from 7 to 8 p.m. You can register for this and any other upcoming Power Hour programs at acr.org/Power Hour. So again, thank you to our faculty and thank you to our international audience here tonight attending this program. Good night, everybody.